Welcome, everyone. No doubt we'll have a few more people joining as we get underway, but thanks for being here. My name is Colin Kinner. I'm the creator of the COVID Safety for Schools course that I know many of you are already familiar with, and it's great to be able to welcome you to what is the second in our series of webinars. This webinar sits alongside the COVID Safety for Schools course. That course is a free online resource for parents and school staff who want to learn in more depth about COVID and how to minimize the impact of all airborne viruses in schools. The topic for tonight's webinar is COVID myth busting. And in a minute, I'll introduce our presenter, Dr. Noor Bari. We're talking about myth busting because there are a lot of myths around about COVID. And the reality is that a lot of people's views about COVID have been influenced by misinformation, which unfortunately is extremely widespread. As you'll hear tonight, misinformation has had a negative impact, not just on individuals, but also on how schools are responding to the threats posed by COVID. So in this webinar, we're going to aim to address some of the most common myths, debunk some misinformation, and give you a summary of the facts about COVID based on the latest science. We're recording this webinar and we'll, of course, share it on the website for anyone who hasn't been able to join us live. If you have a question, we will have some time for Q&A after the presentation. So if you have a question, can you please type it in the Zoom Q&A? You'll see a button at the bottom of your Zoom screen. And we'll make sure that we leave plenty of time for questions. We've had quite a few people submit questions already, so we're going to do our best to get to as many of those as we can. Before we start the webinar, I'd also like to acknowledge the traditional owners of the lands on which we're meeting tonight and to pay my respects to elders past and present. So I'm delighted to be able to introduce our presenter for tonight, Dr. Noor Bari. Dr. Bari is a medical doctor with experience in emergency medicine and training in infectious diseases. She's invested a large amount of her time staying well informed about the science relating to COVID. And there's been a lot published over the last 5 years, so literally thousands of papers. So since the beginning of the pandemic, Noor has treated patients both in the acute phase of a COVID infection and also shared her knowledge with a lot of families about the longer-term impacts of COVID, which we'll get onto, no doubt, tonight. So she's extremely well qualified to talk to us about this topic tonight.
Thanks, Colin. I would also like to acknowledge the traditional custodians of the country and of their connections to the land, sea and community, and pay my respect to elders past, present, and extend that respect to all the there's just been an absolute ton of information flowing since COVID started, and it's very overwhelming, and sometimes things get lost in the communications, and sometimes things are communicated by people that don't quite understand the science yet, and so it can get really confusing. There are far too many myths for me to cover them all today. When I was asked to do this talk, I started with a few, and they just kept popping out of every corner. So I'll try and do my best to cover the main ones, the ones that will hopefully help people keep themselves safe. And then we'll see what else we have time for. So I've got quite a few there. We won't get to see all of them, unfortunately. But I really want to start off very quickly, just a 4-minute talk on airborne transmission, because this is one of the reasons that a lot of the other myths come about. So you'll see these signs everywhere: keep your distance 1.5 meters. And people think, look, if I'm safe, you know, if I'm more than 1.5 meters away or 2 meters away, I'm safe. And we've been told over and over again that COVID is spread by droplets and that they drop down fairly quickly within this distance. But the reality is COVID floats. COVID is airborne, and it's spread by fine floating aerosol, and it floats like smoke, and it can fill rooms, buildings, travel exactly the way you'd expect cigarette smoke or smoke from a fire to travel. And you can get infected anywhere where that gathers in a large enough quantity to infect you. So if it's not well ventilated or it's a bit of a corner, you know, That's what will happen. And the reason that this myth came about is because people confused correlation and causation. They saw large droplets in that close-up space, but the reality is that aerosols are also in the largest amount closest to the source, exactly as you can see from this spray can coming out. You'll get the most paint the closer you are to the aerosol can. And sometimes we don't see that because when a disease first starts, it might not be well adapted to us yet. So we need a bigger viral load before we get infected. So we think we have to be close up for this thing to happen. But eventually it turns out that, it's floating and it gets better at knowing us and it gets better at transmitting. And then it becomes obvious how it's been transmitting the whole time. So it's the small droplets, the small fine mist smoke type thing that we're interested in. Let's have a look at this thing called aerosol, breathing it out all of the time, even if we're just talking, breathing quietly. I'm breathing out now, singing, coughing, and sneezing. And when this smoke builds up, it's not good for us. We used to live in an environment that was very open, with, houses that were much draftier than they are now, buildings that were much taller. And now we live in engineered for heat preservation or AC, to keep us cool, well-sealed units. And this is what our rooms really look like once we've been in them for a day or so, If you don't change the air, you don't have a filter, your room is going to look exactly like that fish tank. You just can't see it. So we've proven that it's the little droplets, not the big droplets, that carry the aerosol. You might think a big droplet is big, so it's carrying more stuff, but no, not really. This fantastic group, led by Kristen Coleman, used this thing that looks a bit like a vacuum cleaner. The person is talking and singing into it, and they captured all of the little droplets from people that do and don't have symptoms. And this slide is a little bit messy, but you only really need to look at the red bits. So let me see if I can get a pointer. Okay, let's have a look.
We can see your mouse pointer,
Can you?
Noah, so that's all good.
So this red box here is the one that we're interested in. It is the fine aerosol, and it is the one that they managed to grow the virus from. Okay, so you can see that the fine aerosol, you can grow virus from it. The other two red ones are saliva. So they actually took a sample of saliva and a swab from the middle of the nose. And we know that that carries virus because that's what we've been testing all this time. The big droplets are over here, where it's just blue and this one tiny little isolated dot there. And as you can see, the big droplets aren't really where the issue is. It's all in these very fine mists. So, and we've proven that it's aerosol. This is a very famous case where you can see the person sitting here with the red dot piano and everyone behind them got infected. Now, there's a way that a droplet that's dropping to the floor within 2 meters did that. And the problems with this is that people think that you can stop disease transmitting between people using curtains, plexiglass. People are taking their masks off, as soon as they're 2 meters away, whether that's hospitals, schools, anywhere, and it's just not the right way to think about it. You need to take your mask breaks or take your mask off in actual fresh air, which is usually outdoors. So and also using the wrong kind of masks. If you're not using a mask that is well fitted around your face, and fit is the most important thing. You can, go through all the choices of what you can and can't afford and what feels nice and what doesn't feel nice. But the most important thing is fit and then the filter. So, this is to keep breathing through the material that you've chosen, not around it, which will then really, really make it much less effective. And it also has gone into a huge problem of when studies were designed, people did not understand this floating smoke issue. And so when they looked for contact tracing or they tried to work out who might be part of this cluster or where did this cluster come from, how did this household get infected, they couldn't do it because they couldn't figure out that this thing had floated like smoke in a large space. And so someone has caught it that way. And so it misses out a lot of the transmission, and it's affected all of the work probably in the first few years of the pandemic. Very few scientists actually managed to account for the real transmission route of this bug. So does that mean that physical distancing doesn't matter? The closer you are to the source, if you remember that spray can, the closer you are to the source, the higher the risk. But when you're indoors, if you haven't cleaned that air somehow, ventilated it, filtered it, if you haven't done that, there is significant risk everywhere that exactly like that fish tank, you are in the same dirty water, it's the same dirty air, okay? Outdoors is much less dangerous than indoors, but it can still happen. So that's that one. And I think the other important thing that I wanted to talk about was outdoor transmission, because I know that confuses a lot of people. Um, this is the kind of thing that people are doing when trying to meet up with family and friends outdoors. And it's really what we wish we could do, I guess. But what happens when you are um, trying to think about COVID transmission in this setting, if you're trying to stop it from happening, is it possible? And the short answer is, unfortunately, it is possible. We've known that outdoor transmission can happen since 2020, when a couple of people had a long outdoor conversation with each other at conversation distance. So you can see that this is a length of time factor. There's a distance factor as well. They're quite close to each other. And the famous case of the night market, which had a spectacular amount of outdoor transmission. If you look at the environment, you can see it's fairly crowded. You can see that there are various structures there, little roofs, little walls, even though they're not altogether continuous, it's still an outdoor environment. You can see that it's a complex environment and it's nighttime. Now, on the left here is where this person went shopping in this little grey box here. And the red boxes are the stalls. The food, I think that's the food. No, that's the shopping bit. Those are the stalls where they went shopping, and the red ones are the ones where people got infected. And you can see that it's quite far away and it's outdoors. So this smoke, this fine, fine aerosol has managed to get to those locations just floating on the night wind. On the right here, you can see that they were walking down here, all of the speckled boxes, these grey speckled boxes, and even this red speckled box here, and a few more here. They're where the person stopped to do something, and the bright red ones is where everyone got infected. And you can see some of those do not have speckles in them. So that is a distance, quite a distance that COVID has floated and managed to infect somebody. And it infected lots of people. All of these blue boxes are people that got infected that one night by that one group of 3 people walking through a market. So, and we're very, very sure that this is what's happened because they did not have COVID circulating freely at the time. So we know who the index cases are, and this is a very tightly contact traced case. So the bottom line is outdoors is much, much safer than indoors. If you're going to do something, please choose outdoors. But be mindful that if you really want to stay safe out there, you want to avoid crowds. You want to avoid close contact. So for me, I use conversation distance. If I'm going to have a conversation with someone, even if it's outdoors, I'll be wearing a mask. Think about microenvironments. You know, you want to go outside, you want to have your sandwich in peace and safety. Don't choose a little corner that doesn't actually get a lot of the outdoor air. You know, actually go and find a proper space if you can. Other factors that might affect it is that some people might be shedding a much larger load than others, and you'll not know who that is. And I do wonder in this particular case whether the fact that it was nighttime made a difference, because you wouldn't have got the UV light and the heat from the sun evaporating those droplets faster and drying them out. So yeah, that was a pretty interesting case. And I don't want, people to think, oh my goodness, it's everywhere, I can't do anything about it. Outdoors is still much safer than indoors. You just have to be a bit more careful when you really don't want to get COVID. Okay, so I'm just going to go back to the beginning slide, and Colin, you can guide me as to what we want to talk about as to where we go next.
Sure. We've had a bunch of questions already. I might start firing some of them at you, and we'll see where we get to. We have one from Rob who says, "Is it safe to fly in planes?"
Is it safe to fly in planes? Um, we know that COVID can spread in planes. I did not bring a plane study with me today to share with you, but it can. Planes, I'm not an aero engineer either. All I'm aware of is all the contact tracing studies and things that have been done. So we know it has spread in planes. Um, you need to think about the entire process from entering the airport, using bathrooms, getting through identity checks, and then getting on board the plane through those narrow little tunnels that you go through. Um, you need to take into account the fact that you're going to be sitting very close next to somebody. So the planes, when they're flying, have very good filtration, is my understanding. But if someone's right next to you, that stuff does not have any time to go through the filter before it goes through you. So you need to take all of these things into account. The bottom line is that everything in life has a certain amount of risk. People have managed to do this without getting infected, but it does have a lot of to get through, particularly the ID checks. And I hope that's helpful.
Thanks, Noor. Um, you said at the outset that one of the reasons that we're still in the situation we are with the pandemic is that COVID's airborne and therefore it's very transmissible. The other factor that I think probably there are some myths or misunderstandings around is when people are infectious. So do you want to talk a bit about, and then there's been several questions on this topic, talk a bit about how long people are infectious for, whether they're infectious before they have symptoms, or obviously the advice that a lot of people are given, particularly in schools, is if you feel sick, stay home, which is good advice, of course. But I suspect there's more
Yeah.
to it that we should talk about.
Yeah. So I do have a little bit to share on this one. Um, when you're feeling well, can you spread disease? I feel well, I can't spread disease is the myth. And the other one is, look, I don't need to wear a mask unless I'm actually feeling unwell. But how did that come about? And if you recall, we were, understanding transmission without symptoms right up until Omicron turned up. And then suddenly every precaution in every setting was dropped. Suddenly Omicron, not only was it mild, but we didn't worry about the fact that well people could transmit it anymore. And the real and everyone took their mask off and said, don't worry about it. But the question is why? What made authorities think that it was fine? And what is the reality? So let's have a look. I actually found the studies that the governments around the world have been looking at. And there are three studies. These three studies. I'm going to start with Jin et al. I hope I've said the name right. I apologize if I haven't. And it was done in China. Now, this is probably the best study. And because it was properly contact traced and there was asymptomatic testing, it was a manageable group size. And what they did was they already had some immunity from the Sinopharm vaccine. This was an Omicron BA 1.1 outbreak. Where I've drawn the purple line on their diagram is when symptoms start, day 0 of symptoms. Okay, and the black dots going up are cumulative transmission. So obviously it starts off at 0-ish, where nobody's got it yet from anybody, and it climbs up to essentially 1 or the equivalent of 100% of all the transmissions that they looked at. And you can see that before the purple line, there's a substantial amount of transmission happening here. It's not as much as after the line, but it does exist and it's not small. And so they estimated that 33% of the transmission occurred without any symptoms or prior to any symptoms. That is a lot of transmission for a disease that is as fast as Omicron. Omicron is faster than Delta. Omicron is very fast indeed. You have 33% transmission of an airborne, highly infectious virus. That's going to be a lot of spread. So even though proportionally it's less than the previous variants spreading asymptomatically, it's still a lot, especially when you take into account how fast it goes. This one is, I think, the Spanish study. And you can see again where 0 is, that's the time from symptom onset. And you can see in various different states of, prior immunity, you can see that Delta and Omicron both spread before 0, so the blue line and the orange line. The blue line is the one we're interested in. And you can see that in some cases, quite a bit of it is before transmission. And in their study, they estimated about 50% of the transmission is happening before symptoms. If you're going to let half the problem as large as COVID go and not bother to wear a mask and take precautions for it, then we're going to have a problem. It's, and it's quite evident in what we're living through. This is just showing that each of the variants are just getting faster and faster as they transmit. So yeah, basically, definitely asymptomatic transmission is still a thing. The very interesting thing was Jin al found that although the transmission window, the mean time, is quite short, they think it's about 0.7 days, 33% of transmission has happened in that tiny snapshot of time. And that tells you how infectious this stuff is, how fast it is. It's not to be played with. So it's you say to an administrator, for 0.7 days worth of transmission, should we wear a mask? And they say, oh, well, no, not really. That's like a few hours. But actually, all that disease has spread. 33% of the transmission has happened. And that's leading to the situation we're in. Yeah.
That's a really important point. I've got a question here from someone who's asking about rat tests, and I think this is also something that is a pretty key part of the picture in terms of understanding how and why COVID spreads so well in environments like schools. So the question is can you talk about rats, and particularly given that we know that people have friends or co-workers who'll do a single rat test and say, it was negative, and therefore I'm certain that I haven't got COVID and I'm okay to come to school or come to work or whatever it might be. Do you want to talk a bit
Yeah.
about what that
Yeah.
really means?
Let's take a look at rat tests. Oh, this is one of my rat tests. I've had quite a few blank rat tests. But every time I've had symptoms of any sort, I have, hay fever, so my nose is constantly a problem. I take precautions because you're going to see why I bothered to do this with my hay fever. So number one, COVID is everywhere. It's highly prevalent. Okay, if you bother to follow the news on COVID, you'll know when the prevalence is up or down, and down is still really, really high. It is higher than it has ever been during any of our so-called pandemic time, when we were, taking precautions, and we know how it spread back then. With the contact tracing, they'll tell us, an entire train full of people need to go and get tested, etc. It's ridiculously high at all times, and sometimes much higher than others. So the chances, so that's what we call the pre-test probability. It's always around. So the pre-test probability is it's going to be high, okay? And then what happens? Rats can be negative for several days while you have symptoms of COVID. Days. You just want to know, don't you? You've got a bit of a sniffle, you take a test, you just want to know, you just want that peace of mind. It's just not possible. If you look at the purple line on this slide, that is the high sensitivity rat tests. And the pink one are for the lower, not so great tests. And if you look at the viral load that's been released by people with Omicron, this has been done using PCR. All these little black dots are somebody's measurement of how much virus they had on that particular day. And if you look at this is the number of days since the symptoms started. So day 0, they have symptoms. You look at the purple line there, and then all these people above the purple line, right, won't get picked up by this test, okay? And you have the same issue going on with day 2, day 3, day 4. And so 40 to 70% of infections, 40 to 70%, 70% is a lot of missed infections. will be missed if you only test once as soon as you have symptoms. That first day test, if it's positive, you've got it. If it's negative, it is not enough to say that you don't have COVID. You almost certainly need to test again, especially with the amount of COVID we've got going around. Even if you test at the peak day, which they say is around day 4, when you can see all the black lines, black dots, sorry, are sort of gathered towards the bottom of this thing, which actually means a higher viral load. And most of these dots you can see are underneath the purple line, right? So they say day 4 is the best day to test. You still miss 20% of cases. So the advice that if you're sick, you should stay home and wear a well-fitted mask is there for a reason. It's because your rat test cannot actually say that you don't have COVID. It can only tell you if you do.
Thanks, that's really helpful. I guess a lot of the things that we're talking about so far are about how COVID spreads and how to be doing things that will minimize the risk of it spreading. The obvious question that we haven't got to yet, and maybe now's a good time to get to it, is the why. Why should we care much about this? People have had colds and flus for forever. There seems to be a widely held perception that COVID cannot be treated like a cold or a flu, and therefore we don't need to be too concerned. And there's a question here from Sarah, which says, what is long COVID and how serious is it? So maybe that's a good starting point to unpack, the why of why should we, particularly in the context of schools, why should we care about this? Sorry, I'll mute myself. There are several questions that I think are asking more or less the same question, which is, okay, most people who get COVID seem to recover from the acute infection reasonably well. There are exceptions to that, of course, which you've alluded to. But I think what's less well understood is the long-term impacts that can follow the acute infection, and long COVID is a big part of that. And to the theme of myths and misinformation, I think there's quite a lot of misinformation out there that suggests that long COVID either is extremely rare or doesn't really exist, or it's really just like the symptoms that follow other viruses like the flu. So I think that's probably the question on quite a few people's minds.
Okay, so I think the first thing that's important to understand is that all of the data that we ever compare COVID data to actually includes colds and flus. So it's generally compared to how we lived beforehand. And we had flu, and we had ME, and we had colds, and we had things like Still's disease, autoimmune issues, diabetes turning up after colds. We had heart attacks after flu. All of that is actually part of what I would think of as the baseline statistics. Everything that we compare, what does COVID do? All the research that's done, they try to find that to compare it to. And sometimes they succeed, sometimes not so much, because it's hard to find groups that don't have COVID now. But that is already part of the data. So every time somebody says, well, COVID increases something by, twice, it's twice compared to colds and flu. So COVID is a cold, is a common one. Like, I don't have to worry about it. But from a doctor's point of view, it's completely meaningless. When a patient comes in and says to me, I have a cold, that doesn't actually tell me anything. They have to tell me, do they have a sore throat? Do they have a runny nose? Do they have difficulty breathing? And then I think about, what does that cold mean for that person? Is this a baby that's going to get bronchiolitis in 3 days' time and end up in ICU? Is this my heart failure patient that's going to end up on respiratory support by tonight? A cold is not the same thing for everyone. And I think for a very long time, we've completely misunderstood that. But okay, so for the larger majority, a cold is less of an issue than it will be for COVID, and we'll have a look at why. I think when people write in newspapers or talk about it amongst themselves, what they're actually saying when it's a cold is, look, this is something familiar. We've had it before, and it's probably harmless because it didn't kill us the last 99 times we've had a cold. Or the other hundreds of other viruses we've tolerated. So familiar and harmless, I think, is what people mean when they say COVID is a cold. And it doesn't, it's a very badly defined in science. There are a bunch of viruses, coronaviruses, flu viruses, adenoviruses, enteroviruses, and they cause upper respiratory tract infections, but some of them actually cause horrific brain inflammation, like enterovirus is quite nasty like that. But equally, Epstein-Barr virus will give you a sore throat, but nobody calls that a cold. So it's very, very poorly defined. I don't actually know what to do with whether or not it's a cold. I don't think it's, I think familiar and harmless is what we're going to work with. And the real question is a COVID familiar and harmless? And I'm going to say no. I think that the mortality baseline is rising, life expectancy is falling, access to healthcare is very difficult for a huge number of patients now. It's affecting our quality of life. Long COVID, we've already mentioned, complications like strokes, heart attacks, clots, other infections, dementia, all going up. It's spoiling our life. It's spoiling our holidays, our important events. It's having a devastating impact on our economy and social impacts as well. So we'll have a look at some of those. With deaths, it's important to understand excess deaths. Excess deaths, I prefer to use them because when you have a new disease, you don't actually know how many different ways it's going to kill you. The most common way and the most, dramatic way that was the first couple of years is that it was, having a big issue in the lungs, and lots of, obvious respiratory issues. Everyone talked about the ventilators and the BiPAP and this kind of thing. So, but that has changed. Omicron, Delta, Alpha, they all behave slightly differently, and Omicron is not one either. It's got many flavors that tend to do one thing or another. So, excess death is what I prefer to think about, and COVID deaths themselves depend a lot on testing. So if people have less access to testing, if they don't test because they're not interested, if doctors miss it because it's behaving differently. For example, if an elderly person comes in with a fall and you don't think that this could be because they're a bit unwell with COVID, you'll miss it, which is something that happens frequently with COVID. So it's all about recognition of death and including it in the numbers. And you can see here that as we reduced the access and the need for testing, so each grey box starts some new end of something, end of PCR testing, end of free rat access, end of needing to isolate, end of needing to report positive rats, and closing the last PCR clinic. And you can see that I mean, there's multiple reasons why the COVID death count is coming down, but if you're not looking, you won't see. And this is the mortality. Now, this is New South Wales numbers. I liked this chart because it really shows it quite clearly, but it's happening all over the world. This is the new abnormal. Now, a few things here you can see up here. There's this very severe 2017 flu season. It was horrific. I remember it well. And then you can see from 2017, there's a very gradual rise in the death rate. In 2020, you'll see the only time that it kind of actually went down. And then you see this 2021 entry wave. I call it entry wave into the pandemic because that's when we joined in with the fun. And you can see the 2022 waves of deaths, and you can then see 2023 also above the red line. But even more importantly, if you look very closely, can you see that these waves are all going up and up? If you look at this line here and compare it to there, this top of this red line is getting closer and closer and closer to this line, and at some point it's going to cross it. Now, the gray area is what they call, what we're expecting to see. And this gray area is being adjusted according to what we've just seen. And so when they say deaths are as expected in the news, what they mean is it's getting worse and worse, but we've accounted for it. So, this is not going back to having a cold. This period over here, sort of between 2018, 2019, let's say, that was, normal flus and cold, okay? This is not. We're not there yet. And I don't know if we'll ever get there. So this is not behaving anything like what we knew before. It's doing its own thing, and we'll get to know it. Um, Here is the life expectancy you can see, and you can see for the first time ever in the last 2 years, this done in 2-year chunks, from the ABS, you can see that first dip. Now, a lot of experts have been on TV and said, well, at some point it had to plateau. We couldn't just keep living forever, right? So, but it's a wild coincidence that it happened at the same time that we've just let a new virus in that happens to kill people by quite large numbers. So I think we shall see how that goes. COVID, gosh, it doesn't. To 50, but you start looking at how people are lying, it's because they're defining it in different ways. And depending on what you take into account, it may vastly change what you're looking at. Now, from my point of view, I think that if you have any lingering symptoms, that should be accounted for as long COVID, because it is a hint that something is not right and it's part of the process. You could be at the milder end of the process, and it doesn't mean it's not happening. And we need to know how many people have this process going on, because as we'll find out in a minute, it's quite it's something that can cause bigger problems later on, right? So we need to actually get a handle on that. So what do we think long COVID might look like? Maybe around 10% of COVID-19 patients, maybe more. We think there's a burden of about 400 million people with COVID in the world. That's a lot of people sick now that weren't sick before. And the dollar cost of this is estimated as $1 trillion US dollars. So more. And it's huge. And you can see that it affects everything here on this little diagram, from your chest pains, heart problems, the heart actually not working, being inflamed, lungs not working. There's nothing that doesn't get touched by COVID. Every organ gets touched by COVID. And I think that, when you come back, you can pause on this slide and have a really good look at this, because I don't have time to go through all of it, unfortunately. It is thought to be a combination of persistent viral infection. This thing is not just coming in and leaving, it's trying to take up residence. The immune system not working properly, the mitochondria, which are the batteries, the power cells of our cells, okay? Complement, which is part of our immune system, not working. Endothelium is the lining inside the blood vessel, not working, and that's important stuff. And microbiome, so we're a city of bugs and our own cells. And what you want is to have good bugs living with your cells and cooperating. And COVID messes that up and increases the number of bad bugs. And that can make people feel very uncomfortable and can even cause disease processes. Things like, Crohn's and ulcerative colitis are associated with bad bugs. So in the Australian economy, it's probably cost us $9.6 billion in 2022, in terms of hours lost. That is a huge amount of money. And 55,000 children aged 4 and under are thought to have long COVID. I mean, that is a devastating number of children who would have been previously reasonably well, and point of fact, to diagnose something is wrong in such a young age group requires obvious symptoms. Most people do not have great skills of picking up illness in pre-verbal children. If something really looks wrong for parents and doctors and teachers and everyone to notice. The other complications of COVID, the other acute, nasty complications of COVID, again, come back and have a really good look at this slide. There are serious issues with having COVID floating around. Heart attacks, heart failure, pneumonias. Pneumonia is a killer at any age. Blood problems like big clots in your lungs that can kill you. Blood clots in the deep veins of your legs. Organs not working properly. Vasculitis is a horrible thing to have. It can occur anywhere in your body and cause any of your organs to not work. Your skin looking funny, red, looking like you've been frostbitten, etc. Strokes. COVID can actually cause an encephalitis, which is a brain infection, amongst all the other things it does. Some variants do more of this than others. liver failure, kidney failure, multiple other secondary infections, viral infections, things like shingles, etc. These all get triggered off after people have COVID. So it's a huge problem having this stuff hanging around. It's impacting education. We all know this. Look at this. This nice big purple chunk is sick leave. It's been all over the news. You can see on the top graph, you can see that school attendance, and you can see the dip recently over the last couple of years. And that's what they're trying to fix. And then this big purple thing is sick. The blue part is unexplained. So some part of that will also be sickness. And to be fair, if you divvy it up, the way the rest of the pie chart is divvied up, that is a lot of sickness. And it's been, this thing of attempting to get ill to get well is just making us more ill. It's not working at all. So, and this other thing of, well, it's not just COVID, it's flu, it's RSV. Well, you know what? They all spread the same way. They're all causing a problem. So if you just try and do the same things for all of them, which is cleaning the air, wearing masks, etc., we can get on top of quite a lot of this. And here, this is an interesting one. We're looking at cell counts of this cell called T cell. You'll hear it now and again in the news. They'll say, oh, don't worry about your antibodies dropping down. Your T cells are still there and you'll have memory, etc. Okay. What's really happening is that the T cells are getting memory. That is genuine. But they're also getting depleted in numbers. Now, the darker gray boxes are COVID numbers. And the cells that you might be familiar with are the CD8 cells. Those are the ones that they say will keep the memory against COVID. Well, you can see that on this chart, this one here, the CD8 cells are very low. Can you see that? It's way low down there. Both these are basically acute infections. Now, they do recover slowly over time, but if you spend some time with your T cells hanging about in the pits, then during that time, you're more susceptible to infections. And if we're getting reinfected every now and again, the T cells are just going to be low, trying to climb up, low, trying to climb up. And then you spend more time in that susceptible phase where any other infection can get you. So
No, can I ask you a question at that point? Because a few people have posted questions. I'm going to read one here from Sarah, which I think is very relevant. She says there's a belief that a lot of these terrible health outcomes develop as a result of COVID and long COVID, but only in people who were already chronically ill. Is there any truth to that?
no. No, there is, I don't have this study with me right now, but there are risk factors for developing long COVID, and they are not necessarily that you are ill. One of the risk factors, for example, is being female. I'd like to think of that as a fairly normal state that quite a few of us are in. So no, I could address that a bit more fully if I have a bit more time, but definitely not. And you'll see it all the time. That generally, in children, a lot of these children, the 55,000 that have long COVID, they wouldn't have had any much significant illness beforehand. In fact, one of the most frequent things I ever hear is, well, he was fine until, I can get you the actual data on that next time, though. I think we'll have to have a next time on this one because there's going to be so much to cover.
For sure.
But you've seen the athletes, you've seen the testimonies from many bright young things that were, sporting, etc. And they do us a great favor by going on TV and stuff and telling us their stories because it's not just sick people getting sick. The most important thing about it, and you can see it in the impact of in the economy, is that it is people that could do stuff that are now not able to do stuff, and the well people that are now becoming sick, and that's what's making the dent.
It's worth mentioning that in the COVID Safety for Schools course, there's a module delivered by Dr. Ray Duncan, who's a UK-based long COVID researcher and cardiologist. She's one of the world's leading authorities on long COVID, and she talks in a bit more detail about some of the things that we're now learning about the impacts of long COVID on kids, adolescents, and adults. So for anyone who's interested in learning more about that particular topic, there's quite a lot of detailed information in the course on it. I think what schools are probably missing most is the what do we do about it? I think every principal and every teacher in the country and worldwide would say, look, I absolutely don't want my students to get sick. I don't want my colleagues to get sick, and I don't want myself to be sick. So I think that's a given. Schools are places where everyone has the right intention of keeping people safe. But I think what seems to be, and certainly my experience in talking to many parents and teachers about this topic, there seems to be a real lack of understanding about what works and what doesn't. And often schools are doing things that, with the best of intentions, they think are going to be really effective, like wiping down desks with disinfectant, that perhaps are really having little or no impact.
So, um, these are the key things that we need to do. Um, First thing is the easiest thing, actually, I think, for most people to do is get fresh air or filtered air. It costs almost nothing if you can open a window to open a window. Obviously, if it's extremely smoky outside, very high pollen counts, if there's something else uncomfortable going outside, then that might be difficult to do. But if you can do it, it is the most cost-effective, rapid way to reduce the amount of stale air carrying virus inside the room. The other thing is filtered air. Now, filtered air has really taken off, I think, because it's got so many benefits, gets the pollen out, gets the smoke out, gets virus out, all kinds of viruses and bacteria out, not just COVID, all the other things that people worry about, flu, RSV, all of it. And there was a fantastic talk. I actually made a slide about it, but it seems to have gone missing in this computer glitching, about a wonderful presentation that was given at the World Indoor Air Quality Day, where Professor, I think it was Robin, said that she did a study of classrooms and they had air filters in one group of classrooms, that mainly naturally ventilated classrooms, and not in the other, and illnesses reduced by 20%. I mean, when you think about the amount of illness absence that we've got, idea of reducing that by 20% would be a huge gain, you know. So cost effective as well. They actually looked into what type of buildings is it cost effective for, and it was most cost effective for public buildings like schools and stuff, because that's where you'd have the biggest impact. That's where most of the disease is spreading. So it's very cost effective. Wearing masks is a very political thing, but it is highly beneficial. I really, really wish that my slides had not disappeared on me. Essentially, you'll see a lot of studies saying the masks don't work. And the reason that they've made that conclusion is because they have had difficulties understanding the aerosol transmission of COVID. So they may have used less effective masks. They may have been taking them off when they shouldn't have been taking them off because they were still indoors sharing air. They may not have understood that you need to fit it well. And these things all impact the studies. And there was a big study, meta-analysis done by Cochrane, which went around the world many times, saying that, we looked at all these studies and masks don't work. And it's not like that at all. Basically, the study didn't show that at all. One of the studies that they included in the meta-analysis, people were only wearing the mask for 1.1% of the time that they should have. So it was not that at all. Basically what that Cochrane meta-analysis really showed is that wearing masks depends on the understanding around wearing masks and the instructions you get around wearing masks and what kind of masks you buy and wear, much more importantly than whether or not the masks actually work. Masks, particularly respirators, work for the entire time that you're wearing it properly fitted on your face, most of the time, well over 99 or 95 at least % of the time, depending which study you look at. And I've been wearing them for years for many, many diseases, and I haven't had one sneak past yet. So these are And there's a brilliant review that I also had on a missing slide that Professor Greenhall did of all of the mask studies, observational studies that they included as well. And it showed there was a beautiful forest plot, and it showed that, the forest plot definitely ends up on the side of wearing masks is beneficial to reducing disease.
I
Um,
think just on the mask question, I think one of the myths perhaps that comes into play in schools is that if someone wants to wear a mask, they should wear it, and that's fine. But
oh,
if
here it
they
is.
don't want to wear one, well, do you want to talk about that and we'll come back?
No, no, it's all right. It's just that tiny little dot. You can see it there. You
Got
can
it.
see the big dots at the bottom of each of these. On the left is if respirators were worn at any point. And you can see that there's a benefit, even if they didn't understand they weren't supposed to take it off away from the patient. And on the right is Professor McIntyre's perfectly formed studies, where you can see that the forest plot, the little diamond on the bottom, is definitely on the side of protection of this line. This sort of down line here, the middle dotted line, is no difference. So you can see that this is definitely on the side of respirators working if you wear them all the time when you're in that
Mm.
dirty tank of the fish water.
Yeah. Or a bus, for example.
Well, this is the thing. It's not just rooms, it's any enclosed environment. If it looks like a fish tank, it is. If you're stuck in a bubble of air, you're sharing it with the other person.
Yeah. What you've got on the screen is what I was about to ask you, which is about mask to source control. So I think a lot of schools are happy with the idea that if a student or a teacher wants to wear a mask, that's fine, that's their choice, and it's to protect them. And I think they often miss the fact that actually masks have a really important role in source control. So it's not just about protecting the wearer, it's about, to your point earlier, that a large proportion of all infections are from people who are pre-symptomatic. It's about recognizing that and saying, well, when you're putting a lot of people in a tightly packed environment, like a bus, for example, if you're on a bus trip for 2 hours and someone on that bus is pre-symptomatic but still infectious, then
Yes.
that would be a great time to have masks.
Absolutely. And you can see, it's very important to point out that on this slide, it is a log scale. So this number here is sort of like, if I'll call that 1, this is 10, and this is 100. Okay. So when you see these lines at a particular distance apart, that's not the distance, it's way longer. And the little pink line down here is the N95 mask. So it's the proper mask that fits all the way around your face, and it has 2 elastic bands that go behind your head, one on the top, one behind the neck. And if you wear one of those, and by the way, this was worn by non-medical people, no training, no fit testing, okay? Despite that, look at that incredible result of how much virus they managed to stop. Okay. Um, and this is so precious. If you're working in healthcare, if you're working in a school or anywhere where everyone needs to go, um, you don't know who's vulnerable around you. People don't walk around with a badge on their head saying, I've got diabetes, I've got asthma, my blood pressure's rotten, I don't know what to do with it. People don't walk around with these labels on their head. You won't know who's going to die. And you can give them, you know, orders of magnitude of protection. It is so worthwhile. Wear any mask that you are comfortable wearing, but if you can wear an N95 mask that fits you properly, you will be doing a great service to everyone around you every day.
I think a minute ago you just skipped over CO2 monitors. I wanted to come back to that because someone has asked a question about it, and I think back to the theme of myths that are affecting the way schools deal with this issue. I think CO2 monitors is probably one of those ones where there's a widely held view that they're a specialist piece of equipment, or you need to be some kind of expert to use them, or they're not appropriate in a classroom. There's lots of barriers that seem to be preventing schools from routinely monitoring the air with a CO2 monitor. Do you want to just talk briefly about what role CO2 monitoring plays and how that can be useful in a school environment?
So CO2 monitors are really simple. If you can read the time on a watch, you can read a CO2 monitor. They are smallish, usually. They will fit in the palm of your hand. Some of them are actually the size of a watch. Yep. And they will give you a number. And that number tells you how much air you're breathing has just been exhaled by somebody else with or without viruses in it. Now, carbon dioxide obviously is the gas that we breathe out, which is what it's detecting. Other things can give you carbon dioxide. For example, if you have an open fire or a gas fire in your home, that will give you higher levels of CO2 than expected. So just take those things into account. But really, if you have a fire in your home anyway, you should be opening the window and having good ventilation. So generally, it's thought 500 for outdoors nowadays, very sadly, is around 450, which is incredibly bad. In terms of greenhouse gases, not in terms of COVID. So that if you're indoors is 450, 500, you're doing really, really well. If you are creeping past 700, it's starting to get a little bit iffy. I don't know if you've got the sticker there, which tells you what percentage it is, but I think it's starting to creep up to about 1%. And then and my CO2 slide has gone missing as well.
Yeah,
I
800,
think it's
1%.
because
2,000 parts per million is about 4% rebreathed air.
yeah, it's quite horrible. I think it's my terrible internet connection. My apologies to everybody, but I live in the no internet zone. And so when I'm downloading these slides, they, some have come and some haven't. And the higher it gets, the more risk you're at. And if you're getting above 1,000, it's starting to get bad. Getting about 1,500, it is time to get out of there. If you can't open the windows and do something about that. When you use a HEPA filter, you can use it in situations where you can't get the CO2 down. HEPA filter will not get the CO2 down, but it will mop up the virus that might be in the air and other stuff. So you are making the air better, even though you're not making the number better. Having said that, carbon dioxide in itself can actually help the virus to survive in the air. There are two factors, carbon dioxide and humidity, and that's another study that's gone missing. It's basically above 40 to 60% is a comfortable room humidity. And as you get higher and higher towards 100% humidity, the virus lives longer and longer. And Omicron is better at doing it than Delta because Omicron's actually got little things that hang on to water molecules to help it survive in the air. That's why it's so annoyingly fast and airborne. Then there is the carbon dioxide level. And if you're at sort of outdoor levels, it's much lower than if you aren't. And it's quite a marked difference. Like as the CO2 climbs to around 2,000, the virus will live for a very long time in the air. So there are good reasons to get the carbon dioxide levels down, as well as your concentration and your general mental acuity.
Yeah, absolutely. Conscious of time, I think we might have time for one or two more questions. What have we not talked about, Noor, that you wanted to touch on before we jump into the last couple of questions?
I'll quickly show you guys that the Cochrane review was actually explained. There was an official explanation for the fact that they accidentally said masks don't work. Here is the evidence that they did actually say the masks don't work on national TV in the US. And here is their retraction of that statement. So if anybody says to you, but there was a massive review from this extremely illustrious place, no, there wasn't. Oh, did we do rapid antigen tests being negative? Oh, did we do rapid antigen tests being positive? Did we do this one? Or if you're still testing positive, what to do?
No, this is a good one. Let's briefly touch on
it. So a lot of people keep getting these pink lines for days, and the government tells you, you're fine after 2 days or 1 day or 5 days or whatever it is that they're saying these days. And then you do a test and it comes up positive, and then you ring up your doctor and say, what do I do? My rapid antigen test is positive, and it's been more than 10 days. And the doctor will maybe accidentally confuse rapid antigen tests and PCR tests, because those are two different things and they show two different results in this context. So very briefly, the yellow stripe here is the rapid antigen test turning positive. The purple stripe here is being able to grow virus from the stuff you're breathing out, okay? The yellow and the purple overlap. That means if your rapid antigen test is positive, you've got growing virus bobbing out of you, okay? So please bear in mind you're infectious. And it's about 90% positive predictive value for being able to grow virus from what you're breathing out. It's very highly likely. 2 lines on a rat test, assume you have COVID, assume you are infectious. PCR is the red stripe, and you can see it doesn't really correlate with growing virus very well. And that is why doctors get that one possibly sometimes confused with the other one. It's very easy to confuse, but now that you've seen the stripes, you will remember that the red stripe didn't go anywhere near it, but the yellow stripe did. Rapid antigen tests means you're growing virus.
I want to come to what's maybe we'll call this the last question, but there are a few people that have asked questions around for schools making sense of the guidance that they're given either by their state Department of Education or by departments of health, or just what they read in the media. I guess for that matter, a lot of what we've been talking about tonight conflicts, at least in part, with some of the guidance that schools are being given. And so there's a question for particularly school leaders, people who have to make decisions about workplace health and safety types of things in schools. What's your view on how schools should make that kind of assessment that says, okay, I'm in a state where, my education department tells me to, let's say, encourage hand washing, but they haven't said really anything about HEPA filters or not much about CO2 monitoring. I'm in Queensland, so that would be a good example where, those things are not covered much, if at all. But you're saying that we should be doing things that focus on ventilation and filtering the air and mask wearing where you've got situations where you can't have really good air that's ventilation or filtration. So how do school leaders make sense of that mismatch?
The mismatch is just because the two different systems work at two different paces. Science on COVID has evolved ridiculously rapidly. There was a 60-year-old myth around the droplet transmission that has been debugged, so to speak, just in the last few years, after many years of trying. This is moving way faster than large organizations can move. It's everything I've spoke to you about here is all backed by the latest evidence. It's all data-based. There is no, I'm not guessing these things. I'm not hoping for these things. But why isn't it being funded? These things are in the pipeline. If you look at the long COVID inquiry, how long it took to do, the outcomes of that recommending ventilation. If you look at the fact that in Victoria, they're now starting to look at actually implementing how we're going to get safer indoor air. They're going to run experiments looking at what works, what doesn't work. This is a slow process, a deliberate and planned process. A large amounts of money may be required, and so it's done carefully. And this is both a good thing. You don't want your government suddenly waking up one morning and spending $12 billion on something you didn't need. But it's also a very bad thing when you have an ongoing emergency, in my view. If people are getting sicker and sicker, kids are getting sicker and sicker, then we need to get a move on. So this is the latest evidence. This is not going to change. It hasn't. We've known quite a lot of this for years. We need to start moving in whatever way we can. And if your government hasn't already made the move, you need to start making the move anyway for your own sake. And even if you don't make all of the moves, do the ones you can. most people, even in very cultures that are very averse to wearing masks, will still be able to get open windows done and HEPA filters done and multiple other things done, like, testing or isolating or whatever. Those things you may still be able to do, and you need to do what you can. This stuff is bad.
Yeah,
You
I
know,
saw a
just
figure from Clean Air Stars that did an estimate of the cost of HEPA filters for a classroom, and it worked out to be $23, this is Australian dollars, per student per year. So
yeah,
that's less than the cost of a textbook. That's
yeah.
for most
And
schools
it
that
will
the
and
cost isn't the barrier. Right?
it will pay itself back multiple times over because you'll have the attendance that you want. You'll have the learning outcomes be improving, and in terms of workplaces, you'll actually have the productivity that you want. We need to improve on all of these parameters.
No, I think we might wrap it up there. That's been hugely valuable. So I just want to thank you for sharing your time and expertise. It's been we've covered a lot, and I know there are a lot of topics that we haven't covered. So I'm going to invite anyone who would like to have other topics covered in future webinars to get in touch via the website, covidsafetyforschools.org. Feel free to get in touch and suggest topics. We have quite a few things that we'd like to cover, and Norm, maybe we'll invite you back to cover some more myths because there's no doubt things that we could talk about for a lot longer.
Yes.
Um, Before we wrap up, I'd also just like to acknowledge the support of CanRo, which is a philanthropic organization that supported us to make these webinars and the entire course freely available for anyone who wants to access it. And also, I'd encourage anyone who hasn't already to sign up for the COVID Safety for Schools course. It's free and it's available via the website, and I think people will find it useful. So, on that note, I'm going to wrap this up. I know there's questions that we haven't got to. We might park them for a future session. But thanks again, Noor, for joining us.
No, thank you for having me. I'm sorry I could not show you everything that I wanted to, but it was good.
Yeah, and thanks
Good to
everyone
have a
for being
chat.
with us. We'll have this recording posted on the website in the next day or so. So thanks very much for being here.
Thanks for having me.